All right, so today's meeting, let me go ahead and get there. Can you guys see my screen okay? We're gonna first have presenter Marta with HIT to come and talk about the health information technology. Then we're gonna have our chairs discuss the liaisons and the chairs updates. Then we're gonna have Jessica Dusick. She's going to discuss the H&M work group and give us an update on the dental OARs. And then we get to have M, who is giving us a legislative update. Then Dave and Meg will be able to join us and have a discussion with just OHA leadership updates. On page 2 of this agenda, you will see the liaisons to the oral health forum. In yellow, just so everybody's aware, are the ones we still need members for. So please consider that to be our liaison, and that would be great. Also, please put your name and who you're affiliated with in the chat, and this helps us tremendously with roll call. And what I'm going to do now is hand it over to Marta, and I'm going to pull up your screens, your PowerPoint. So just give me one moment, and we'll just do that after I met everybody. Okay.
Great. Can you hear me okay?
I can. Yes.
Okay, great. Good morning. My name is Marta Makarushka. I use she, her pronouns, and I'm a lead policy analyst in the Office of Health IT and Analytics Infrastructure at OHA. So I was last here talking with you on this topic back in October, and I am back. I am not sure exactly whether you guys have specific needs on this topic from us. So I went ahead and made the assumption that it would be helpful to go over the health IT data that we currently have for oral health organizations. And then I'm also hoping to just continue to get more input from you all on the topic of health IT within oral health. So you'll see that the questions that are on the in the slides are very similar, and some are the same as last time. I'm not sure that we actually got to discuss many of them, so hopefully we'll have an opportunity to get more input from you today. But I'm always happy to come back. So if you have additional questions or information that you'd like me to bring, I'm happy to come back in a future meeting. We just want to make sure that in part we just have open lines of communication to our office, and if there's anything that OHA can do in supporting this work, that we are aware of it, and that we do what we can to provide that support. So next slide. So first I wanted to talk about what we call EHRs, even though I understand that these may not all be EHRs as maybe we are used to defining them, or as some people consider them. So I am putting it in a bit of air quotes here because we understand that EHRs, or electronic systems for tracking patient information, vary significantly. And within the physical health sphere, there are many more certified systems than there are within oral health. Typically, current certified systems that are certified to the current standards have more information sharing capabilities. That's a requirement of those systems. So it's possible, though, that other systems that are not certified to the current standards still do have some of those functionalities. It's just a little bit harder to know exactly what the functionalities are within each of the systems. So we don't know exactly to what extent the oral health systems are considered electronic health record systems, or whether they are practice management systems or some sort of hybrid system. I would say that at a minimum, electronic health record systems, in order to be considered an electronic health record, generally, that would mean that they have some sort of electronic patient chart. So that is that they are tracking information patient clinical information and electronically, and that information is available. It's captured, it's stored, it's accessed and used electronically. So you can see here that there are 6 specific EHR systems that are listed that we have information on within the oral health landscape here in Oregon. So these are the systems that are used by a minimum of 5 organizations. If a system is used by fewer than 5 organizations, then they are in the other EHR category, which you can see is the 3rd row down. This is information that is tracked for CCO contracted oral health organizations. So basically the organizations that are included on the CCO's, the DSN files that OHA gets and processes. So we use those to help us track the organizations that are contracted by CCOs and what health IT has been adopted and is being used by those organizations. So it is a subset of all the oral health organizations in Oregon. So I do want to make sure that that's clear. But it is the information that we have to share. So we're always looking to gather more information, get access, and report that out. So if there is additional information that we are able to access, we do bring that in as soon as we have it. So you can see that, so this is the numbers that you see on the screen are the numbers of organizations. The next slide I'm going to show you is a weighted percentage of the number of providers that are using the system. So the way that we get to this number
I'm sorry, I tried to
is
time
by
it and I
looking.
didn't do a very good job today.
Sounds
Maybe,
like
please, I
someone's
don't
not
want to
quite on
fight
mute.
with you. Don't.
So if you are, if you could check and make sure that you're muted, that would be great. Thank you.
Don't do that with the shoulders. Don't do that with the shoulders. Stop. Stop.
Or
Stop.
perhaps someone can help mute
Last night you cannot extinguish.
folks that are not currently speaking. Thank you. So the DSN files that we get from the CCOs do have NPIs included. And so it's basically, this is not a complete picture because we're really basing all of our reporting on what's in the CCO DSN files, which is why it's so important to have as much information in there as possible and make sure that it's as accurate as possible. But we go ahead and what's in there. So any NPIs that are in there, we track that information and we roll it up and we say, okay, so for all the providers at that organization, we're going to weight those organizations by the number of providers that are using that system. So you can see that there's a little bit of a difference in terms of which EHR systems are used by the greatest number of organizations versus the greatest number of providers. So the slide we're looking at now is basically taking all the oral health providers that we have information on and saying what system are each provider using, which system is each provider using. And you can see that we are still missing a lot of information. And we do know that some organizations, some providers are not using an EHR, but there are not many. But we do have a lot of information that's still missing. So any questions about these particular slides before we move on to health information exchange?
Yeah, this is Dana. I have a question. So I think I've worked out one of them already, because when you were saying organizations, in my mind, I was thinking of the dental care organizations, but I think you mean like clinics, right? When you're talking about
mean oral health clinics. Yes, you were
okay.
Right. Sorry about that.
So that first slide, there wasn't a lot of context there. So so then your point is that now in this slide, it's the percentage of providers based on what's submitted in the DSN. So the total number of providers on the DSN are represented on this chart.
That's right. Of oral health providers. Yeah.
Right. Right. Okay. Okay. And then are we going to be able to get copies of these slides?
Yeah.
Yes.
Absolutely.
Great. Okay.
Yeah, and we're
okay,
happy
I think
to
that's all my
slice and
questions for
dice the
now.
data.
Thanks.
Okay, yeah, we're happy to slice and dice the data in whatever way is most useful. So if you want more information about, which organizations or yeah, how this all breaks down further, we're happy to provide that. So just let us know. And in part, I mean, for us, it's we are doing what we can to fill in that missing information, but there's little really that we can do. And so we look to the oral health plans and the CCOs to help gather that information. So we expect that that's a collaborative effort between the two. And if there's more that we can do, we can certainly help support those efforts. We, have done surveys in the past. I think typically CCOs and oral health plans have had pretty good success in gathering that information. But if there's anything else that we can do to support it, like provide survey questions or connect folks that have had greater success with folks that are struggling more, we're happy to bring folks together, or anything at all that we can do to help
So I have
support
one
the
more
data
question. This is
collection
Dana
piece.
again.
Yeah.
So what's the difference between other EHR at the top and has EHR but the vendor's unknown?
Yep, that's a good question. So other EHR at the top are EHR systems that we know the vendor, but there are just fewer than 5 organizations using those EHRs. And so rather than list out every single EHR system, we grouped it because you can see even for Carestream Dental, right, it's only at 1%. So the other EHRs are even lower percentages. So again, we can provide you with that full list if that would be helpful. But that's what that represents. And then has EHR vendor unknown is where we know we found out, we have information that they're using some sort of system, but we have no idea what system it is.
And then no EHR is the provider responded to
We
the survey and
know
said,
that
I'm not using an
that's
EHR.
right. That's right.
Right.
That's
And then
right.
missing
You
is
got it.
just
Yep.
they didn't answer at all.
We don't have
Okay.
information. That's right. Yeah, you got it.
And is the goal to reduce the missing column, or is the goal to, what's the goal?
Yes.
From OHA's perspective?
Yes. So, oh, there's so many, so many goals. But yes, one of them is to gather more information so that we have less missing information, for sure. The other, among the others are so we've done some research in terms of the functionality that's available within the different systems. So we have some idea, but we don't necessarily know what those functionalities are, what's being used, where the barriers are, what additional functionality is most needed across your oral health providers. Mainly it's about not just using the information internally, right? It's mostly about making that information available externally, being able to share it with other organizations that are in need of that information to provide the best patient care. So it's really learning what we can about what's the current functionality available to oral health organizations and providers. To what extent is that meeting their needs? To what extent are they needing additional functionality? What kind of information are they? And these are all the questions that follow my data slides. But to what extent are we, is there a need for information sharing tools? What kind of information sharing is needed? So what's the priority for information sharing for oral health? That sort of thing. So we're always looking to understand, what's currently being done, what's working, what's not working, what's needed, and how do we help support meeting those needs.
So in the past, the in my recollection, and correct me if I'm wrong, the EHR, the push to have EHRs in healthcare generally on the medical side was to improve connectivity between providers, correct?
Yep. I mean, that was like, yep, the
And
long-term
to be able,
vision. Yes,
yeah, to be able to report on metrics and be able to do,
that's right.
you know, kind of
got it.
more sophisticated sort of
CDP and-
coordination, right?
That's right. Yeah.
And so I guess if that's the goal, if that's where if OHA is sort of encouraging EHR uptake, for what purpose? You know what I'm saying? Like, I get that it's, you know, maybe makes practices more efficient or whatever, but they're expensive systems. And so maybe if there was an idea in mind of what efficiencies or what benefits you would get out of it, that might help maybe with some of that uptake.
Yeah, it's more about what do oral health providers need and what do the patients need? Like, what do other providers need in terms of information to be able to best address patient needs and best be able to care for the patient? So it's that's the thing is, even for us, we're thinking like, you know, it doesn't make sense to mandate a particular tool if that tool isn't really meeting the priority needs of providers, right? So for us, if we want to better understand what are the priority information needs, right? So both on the oral health side, but also, so oral health could mean the primary oral health provider versus a specialist, and then all the other providers that the patient's working with on the physical health side, behavioral health side. So what information do physical health providers need from oral health providers, and what's the best tool to support that information exchange need? Rather than assuming that, well, everybody would benefit from the same health information exchange tool when it's not really serving the needs or the priorities. So let me go into the next couple slides are about well, this one's still about EHR, and then there's one about health information exchange. So here you can see that over time, right? So this is data. The data that we compiled for these slides is the most recent data we have. So it's based on the DSN files that were submitted, I think a couple quarters ago, but it's actually the data reporting, the health IT data reporting files that were just submitted by CCOs in March. So we went ahead and compiled that information quickly to get this to you, since we only got those files a couple weeks ago. But so this shows you that over the last few years, you can see that EHR use is increasing, and you can see the differences in rates between the unweighted, which is at the organizational level, and the weighted rates, which is at the provider level. So you can see that use is increasing, but there's still the question of, are the systems that are being used, that have been implemented, are they meeting the needs, right? So that's where it's helpful for us to get any input that you have based on your conversations, your interactions with oral health provider clinics, because we don't have that necessarily that connection to the clinics. So there are systems being implemented, being used. What we don't know is to what extent are they meeting the needs, and if they are not, what are the additional functionalities that are needed, and how do we then support the tools that are needed for that, for those functionalities. So then the next slide is so these are the rates of use for Collective, or Point Click Care as it is now known, and Reliance eHealth Collaborative. So there's the two health information exchange tools in use in Oregon, and you can see that there's really no change in the use of those tools over time, and that's mostly because these are representing large, DCO plans that are connected, that have clinics that are being counted, within their organization. So This is mostly representing Advantage and Capital and their connectivity to the tools. So we do not necessarily expect that these rates would necessarily increase, because it's not necessarily the case that oral health provider clinics are the ones that should be leveraging these tools directly, as opposed to, what we've heard over the years time and time again, is that it's really the health plans or the DCOs that are accessing the information and then coordinating with the oral health clinic. So, if that's really the workflow, and the health plans, the DCOs are playing that role, then it's also making sure that we're understanding what the health IT capabilities are at that level, and what the needs are at that level, and making sure that we're informed on, again, any challenges, obstacles, priorities, what would be more helpful in terms of tools for you to have, to make sure that you're able to provide the type of coordination that's needed, information exchange, access to information. And so that's why we then lead into on the next slides, and I know I'm pretty much out of time, but the questions around, exactly what I've been saying throughout here. This slide is really just a quick overview. I mentioned this last time, that the CCOs submit these health IT roadmaps annually, and that they report on all the efforts to support health IT among all provider types. So I know that I want to say all of them, but certainly most of them coordinate with the health plans and DCOs on both the work and the reporting for oral health provider clinics. Next slide. And then this is just going into discussion again. We're a bit out of time again, but yeah, so I think a lot of the questions that follow on these slides, and then the very last slide, you'll get these slides, but the very last slide is it's just a list of a couple of resources, but this is basically just trying to get your input on all the questions that I've just been mentioning. So I'm curious to hear whether you have any input on the health IT priority needs among oral health, what you're seeing as gaps in tools or functionality, any input you have on how OHA can help support efforts in this area. Any questions?
I don't see any hands, but yeah, I've said my piece. So if anyone wants to jump in.
Hey, Dana, it's Laura. Hi, Marta, it's Laura with AllCare. I just wanted to say thank you for coming today and sharing this with us. And I just wanted to express my thanks for understanding how challenging this can be sometimes, because it's difficult.
Yeah, it is difficult. And so when you say it's difficult, what's the it that you're referring to?
Well,
there are many aspects to this. So
yes, there are. That's right. I think difficulty, you have a lot of small practices out there. Some of them are panel providers with the dental care organizations. They're not going to have the ability to fund something like this. It's really expensive. And even, I know the last slide said CCOs are to support. I'm curious as to how you support this endeavor besides funding. I mean, I'm just not sure how you do that. And even doing that, it's still very costly. And, the practice management software, like you mentioned, it's a great tool, but it's not an EHR. And so unless you have the Epic, I think it's Wisdom, if I'm correct, Wisdom Tooth or something like that. It's just difficult. I would say funding probably comes to the top of my mind. How do we help support this? Besides funding, but even funding is very challenging. Because I don't believe you can count this on like CBI or anything like that.
You can use HRS funds to support
can.
health IT.
Okay.
Yeah.
Well, I will take that back then. That's good.
Yeah. So you could see though that right on the EHR list, system doesn't show up, right? Like it's that is not the system that is used by many organizations. So, you know, the interesting to hear again for us, like there are other systems that are implemented, being used, what appears to be successfully, but that's where you guys come in. Like, are these systems sufficient? Do they seem to be working? And perhaps at the oral health provider level, it's enough for them for the most part, but it's more about how do we enable that information exchange that's needed. So what would be needed in order to improve the electronic health information exchange? And maybe, you know, that's a different conversation. Maybe it's not that everyone needs to have a certified system as much as there needs to be a minimum electronic patient chart with data that is stored in a particular format that then is made available, that can be made available for connecting to another system. And maybe the information that needs to be shared is minimal, and maybe, you know, it'd be easier to do that and more feasible to do that in another way, not necessarily using a huge system like Epic's Wisdom. But again, the more that, you know, you guys can share with us your experiences, your knowledge, you know, your insights, because you have the direct connection to the clinics, you know, the more helpful for us. And then, so Dr. Chaudhry, he is a member of the Health IT Oversight Council, so he certainly brings a lot. He brings that dental perspective and brings a lot of input to High Talk every 2 months. He was also a co-chair of the Health Information Exchange work group that met for a year at least. And so again, we had the benefit of his participation in that, with the oral health perspective being, you know, brought to the front there. But it still feels like the more information we can have from, I mean, you all operate very differently. CCOs operate differently. DCOs, health plans, oral health plans operate differently, right? So it is helpful for us to get that broader perspective in case there's anything else that we should know. Any of your experiences that you can share would be helpful. And we're always happy to just meet individually if that would be helpful. If you have input, we're happy to just either hop on a call or, you know, however it is easiest for you to interact. So
it looks like we do have a hand up, Mike.
Yeah, I was just going to say that
Okay.
we've been with. Can you hear me?
Yes, we can.
Yeah, we've been at Kaiser. We were a first mover really in big systems that were outside of academic health centers to do Epic Wisdom, and we have a lot of experience with it from when it was pretty infant to now. And so please reach out to me individually. My contact should be there if you want to talk about that. And we have an entire IT team that's on the medical and dental side that's constantly dealing with Epic. So I don't want to belabor it on this group, but it's not feasible to think that small practices across this state are going to jump on something like Epic, because it requires tremendous resources, time, and is different than pretty much anything else people do in dentistry, because it's mostly it's just a platform built on it's a module built on a medical platform is all it is. So anyway, reach out to me individually if you'd like to talk about that. And if I can't answer your questions, I can get the right people within our system that deals with Epic to talk to you.
That sounds great. Thank you, Michael. And I appreciate that input actually, because that is our sense of it, and it is helpful for others to hear that that yes, it's not necessarily a system that is kind of the gold standard that would work for everyone, and is the system to turn to. It's it's got its challenges. So, well, please reach out with questions, or if you have anything that you are willing to share about your experiences. I know I'm out of time, so thank you so much for giving me this time to talk with you today. If you have any other questions, I'm happy to come back with more information, or if you want information broken down in other ways, just let me know. Otherwise, thank you.
And if anybody would like any additional questions, please feel free to email me. I'll make sure Marta gets everything that she needs. And Marta, thank you so much for being flexible and being here and giving us your time. I do appreciate you. Thank you.
Thank you.
Thanks, Marta.
And just a
Thank
reminder,
you.
I know it was said a couple times, but we're going to have these slides available after the meeting. Now, let me go ahead and share my screen again. It's going to be the chairs who are presenting regarding liaisons and any updates that they might have. And then one thing I'd like to do, just as a reminder, on the second page, we do have the liaisons for the Oral Health Forum to other groups, and in the yellow are still areas where we need liaisons. So I'm going to hand it off to the chairs.
Thanks, Janet. So yeah, this is the list that we sort of came up with in our last meeting as far as people who either volunteered or who were sort of already kind of acting as a liaison for this group, for those work groups. And then these are the work groups that we have listed in our charter, I believe, right, Janet? Which is why they were specifically called out. Yeah, okay. So it's not everything, I guess, is what I'm saying, and we sort of wanted to highlight the I guess the committees that we thought had you know, good information that overlaps with this one. The ones in yellow, we were looking for volunteers, but we also knew we needed to get well, with the MAC, I think we may have a solution there, but with the Oregon Health Policy Board, the last one, the problem with having a liaison for that is that it meets at the same time as this meeting meets. And so having somebody attend that and then report here obviously doesn't work. So, or if we do hear reports, it's a month late because it, you know, they were there last month and skipped our meeting or vice versa. So anyway, I think we, also need to talk and you know, maybe use some of our chair update time to talk about the date and time of this meeting, because originally we moved it to this day to be, you know, to have less meeting conflicts, especially for folks at OHA. So obviously overlapping it with the Oregon Health Policy Board was an oversight. I didn't realize it was on that same day. And I can't remember how we came up with the date, but I'm also wondering whether or not that's something that we consider as changing the date and time of this meeting again. And I kind of hate to do that just because we sort of, you know, doing it too much and people kind of miss the meeting and it's hard to track the schedule. But and there's never going to be a perfect, right? But you know, especially for, you know, Dave or Dr. Carey to be able to attend. I think that was part of our intent with moving it to this date. Laura?
Yeah, Dana, is there any possibility of moving it back to where it aligns with the MEOC and the tech meeting like we used to? Because there won't be any way to be there in person because we're not going to make two separate trips to come to MEOC and then the Oral Health Forum.
Yeah, I'd love to have it back on that Wednesday, like in between tech and MEOC, you mean?
Yes.
You know, I just want to point out, like, I'm happy to do whatever this group would like, but we would have to take into account Dave or Meg's schedule. And that's one reason we're moving this, potentially moving this meeting, because originally there was not a meeting scheduled, or it was on hiatus rather, for Dave's schedule. And then they re-implemented it. And so that's why we're
Well, we
reconsidering.
were originally on Thursday, so it would be the day
Yes.
it would be the day before. Yeah, so I'm wondering whether or not his third Wednesday is open, since there's 2 other work groups.
Third Wednesday?
Yeah, so it's the Wednesday before the third Thursday is when those 2 groups get scheduled.
Are you thinking the same day as the All Plan System Technical and the MEOC meeting? Is
Yes.
that what you're thinking?
Yes.
Yeah, right. Trying to align with
Yeah.
it.
'Cause we used to do
Yeah,
it.
I think as
we
long as
used
you're
to-
able to work around those 2 meetings, it may make sense.
Yeah, that's the way it used to be, Dave. And then, those of us
Yeah.
that came up for MEOC, we could just attend all 3 because we were right there. It was just so convenient.
That makes sense to me.
I'll touch base with Anne and see what we can do, and then send out an email and maybe a poll as well if need be. Does that sound reasonable?
Okay.
Yeah.
Yeah, and so just so people know, that Wednesday is from 9 to 11 is the tech work group, and it's all we call it all plan technical. It was intended to include not just CCOs, but other plan types. Of course, now it's all CCO. But it's called all plan technical, and they talk a lot about the enrollment and MMIS and updates related to that. And then the MEOC work group is the Member Engagement and Outreach Committee, and they meet typically from 2:30 to 3:30. And so we would have time, say, from 1 to 2:30, or if we wanted to do 12:30 to 2 or 2:30, we could squeeze ourselves in there. So I can't tell if somebody's trying to talk. Maybe not. So anyway, I think there's time there, and especially for the in-person days, it would be nice to be able to all be in the building together on the same day. Anyway, we can talk about that if there's interest in doing that. But if it's a handful of people and nobody else wants it on that day, I mean, it would be good to know that as well. So if you don't care, we'll make it convenient for the people who are actually who maybe attend those other meetings. But if that really doesn't work and there's some serious concern about having it on that day, let us know.
Dana, I'm confused with some of the dates that this is Gary Allen that were tossed out there. So what you're saying is on a Wednesday, what Wednesday of the month is that?
It is the
I don't
Wednesday
attend those other
before the
meetings.
third Thursday.
So
So
the
find the
Wednesday,
third Thursday on the calendar, and it's the Wednesday before. And
All right.
that goes way back, to the old contractor work groups, right? So it's typically the third Wednesday, but sometimes it's the fourth Wednesday or the second Wednesday or whatever, because of how the calendar falls. So you just have to find the third Thursday, and then it's the day before.
all right, I think I got it.
And I mean, it doesn't have to be that anymore, because there's nothing that meets on that Thursday anymore to relate it to. I guess that's part of the problem, but that's how they've come up with that calendar.
And then Dana, just for clarification purposes, we have a hybrid meeting coming up in May.
In May, yeah.
So we're going to go ahead and still keep that date. Does that sound reasonable? So we can kind of put this out a little bit to May, April, May, June.
Yeah, give people some time to plan or
Yeah.
whatever.
Okay, so
And
next
I
month
think
is
Anne
still
would
the same.
appreciate that. Yeah.
Yeah. Yeah.
Yeah.
Perfect.
So I think, so we'll meet, like, our next meeting is what, May
7th, I believe.
2nd or something? Yeah, it's like, oh yeah, May 7th. You have it on there. Good. So, and it was, intended to be in person. So we could keep that. And then in June, we would meet on the third week of June on that Wednesday. And let me just look at that really quick while everyone's here. We can just write it down on our calendars.
May I
That's all,
chime in before we write this down in our calendars? I just want to reflect on that we were meeting aligned with the MEOC, and we had to move it because it wasn't working for Meg and Dave. I hear Dave on the call and saying, why?
Okay, Dave can let us know, but it was Thursday, Samantha, not
it was
Wednesday.
Thursday.
Yeah.
Got it. Okay, it wasn't
The
Wednesday.
Thursday,
Cool.
yeah.
Okay.
Yeah.
the previous time was conflicting with the CCO CEO meeting, which was
Yes.
the third Thursday, but third Wednesday is fine.
Thank you for correcting my memory.
For
I
me.
was like, wait, we were aligned with MEAC and we moved away from the MEAC. Why are we going back to the MEAC? Thank you for correcting me. That's helpful. Can we just make sure, like, yes, let's mark it down, but can we send an email to everybody? You know, we have really good turnout today on this meeting, but I think maybe if we could do like do an email and say, hey, get back to us within a week and let us know if this is like a major problem for you, would maybe just help with inclusion of making sure we're considering everyone's processes and calendars. Because I know I never attend, like the MEAC, the 2 meetings you're mentioning are 2 meetings I've never attended regularly, but there's 9,000 other meetings at OHA that I certainly do. And I think just giving it a second would be great. Thank you.
Yeah, so I think what we're suggesting is we would keep our regular meeting in May, which is on the 7th, which is a Tuesday. And then if we change, so we'll send an email out to everybody. You can let us know your thoughts. And if we change, the suggested date would be, the first time we would do it would be in June, and it would be for June 19th, which is a Wednesday. So we'll make sure everyone's got that on the
Yeah, that's
email.
a holiday. It's Juneteenth.
So meaning OHA is
Meaning
closed
yes. It's
on that Wednesday?
Yep.
It wouldn't be like a Monday or Friday?
That only happens if it falls on the weekend.
Oh, okay. Okay. Well,
we can still talk about it.
So we'll throw that in the mix and we'll see. I mean, obviously the other meetings are going to have to move as well.
Yeah.
For that. So anyway.
Okay, perfect.
Hold on to your seatbelts, folks. So we'll figure it
Dana,
out. But
Dana, this is Heather.
Yes, Heather. Yeah.
I guess I'm interested in sort of this poll that it sounds like we're going to do on meeting dates. I do have multiple meeting conflicts at this point if we move it. I'm sure I'm not the only one. So I would prefer staying with what we have. It sounds like, I mean, we only
that's going to be the question that you get in the email.
But we're only meeting in person periodically. And I also don't attend these other meetings. So I just want to throw it out there that for those who do travel, I understand this will be better for them, but I mean, it's challenging to continuously change these meetings to different dates. So I'm just going to throw it out there.
Well, that will also, I think you bring up a good point, Heather, is how can we, if we do need to change the meeting for whatever reason, or we don't, how can we still accommodate the needs of like having leadership here? Or if there's another idea out there that we haven't thought of, that would be tremendously supported as well. But I will send out a poll later this week once I square things away with Anne. And like we said, nothing's in stone yet. We still have May, which is our hybrid. June, there's a big wrinkle. So with the holiday, but we'll continue this conversation via email if that is okay.
Yeah, make sure you make your voice heard if you have an opinion about it, because that'll be your chance. Okay, and I didn't have any other chair updates. And Laura, do you have anything to add?
No. Did we want to talk about the other meetings? I did not attend QHawk this month. I had a conflict. Oh, Sam, did you have a question?
I just wanted to quickly call out the chat conversation that's happening and make sure Laura and Janet, sorry, Laura, you're speaking. If Janet and Dana saw it. Thank you. That's it, Laura.
Okay, I'll give them a chance to read it. I did not attend QHawk this month, Dana, but I know that they did talk about the RAC for the local dental sealant programs.
Yeah.
There was some information about that. Had the RAC meeting times. anybody needs those, we can get them to you. They did also talk about the dental director recruitment, and the deadline to apply has passed. It seems it was 3/31. I think toward the end of the meeting, we might have an update on that. And let's see, talks about the position and what the dental director will do within HSD. And that was it for anything dental at QHawk. Or I'm trying to think, Dana, did you attend contracts and compliance last week? I was spotty in and out because I was traveling. They did talk about HRSN, I think.
Yeah, it was focused actually a lot on the, good, Kathy's here too, so she can say.
Oh,
they
good,
focused a lot on the new contract requirements for 2025.
Yes.
And there are quite a few of those, so.
Yes, there are.
I can send you the link to the document on there if that's easier for people, but there was a lot of conversation about 2025 changes, deliverables. I think the one that kind of brought concern, not so much for some of the larger organizations, but some of the smaller ones, was regarding the phone tree changes, requirements. That could be a big change for some people. Requiring, basically it's simplifying the ability to get to a appropriate language and directions on that to ensure that your phone trees allow that. And it is specifically external to that. There is also another concern, and I'm not quite sure how big of a concern this is for people, but it felt a little granular for what they're looking for. And this has to do with the quarterly reports that the CCOs provide the state. And you already report any caps that go to the state or that are with your plan partners. However, now they didn't describe it very well, but what they're looking for is any finding or issues you may be having with one of your plans, whether it goes to a cap or not. They want that reported in the quarterly, which brought up a lot of conversation on really how in the weeds or nitpicky are you going to be about this, and how reasonable is this to ask, because it may be a 2-day conversation between a plan and the CCO versus something that takes 3 weeks to report back. So and Cheryl might be able to provide additional context to this, but that's kind of where the take on that was. Cheryl, did you have something to add to that?
Yeah, hi folks, this is Cheryl Henning, CCO Contract Administrator. I've been sort of lurking in the background, but I heard Catherine talking about this topic. I can't comment on the specific changes, but I want to just alert the folks on this call to the process. So what Catherine's referring to is the presentations we did to CCOs for this set of proposed significant changes for 25. And so CCOs had an opportunity for feedback during the presentations and also in writing by last Friday. And then those presentations or those changes will go internally for approval consideration this Thursday. And so the presenters do have to explain what CCO comments they received and how they've addressed those CCO feedbacks. So the changes as described in those initial CCO presentations, those are not necessarily what will actually go into the literal contract. So whatever gets approved internally this week by leadership, that will be represented in contract language in the initial draft that CCOs will receive in mid-June. So CCOs will have about a month to give written feedback again. So these presentations that Kathy's describing are preliminary. They're not done. And CCOs will be able to give feedback again in June.
Okay, thank you, Cheryl. Yeah, and again, these are 2025. So by June, maybe by the June contracts meeting, that will be available, the draft or what became approved of these draft pieces.
When you say contract meeting, do you mean the contracts and compliance meeting?
Yes.
Yes, yeah. So the initial draft goes out to CCOs on June 12th. And so yes, that red line document will be publicly available in time for that CNC meeting. And then I assume too that CCOs will communicate downstream with the DCOs about changes in the contract that might implicate their subcontracts. So you would be working with your CCOs to understand how any of the contract changes would affect the DCOs.
Great, thank you.
You bet.
And so that there, and so along with that, again, deliverables, that's something for 2025 changes that, as Cheryl mentioned, will come out in the draft changes of what is accepted. But I would look at this, if you have an opportunity to look at the presentation and the proposed changes and deliverables as they move forward. And the deliverable changes are intended to be to support the administrative simplification, kind of combining and simplifying the deliverables. And I do appreciate the, there is a slide in there that demonstrates the deliverables associated with a category. So take a look at that. That's all I have.
Thanks, Kathy. Yep, that's all those slides are on the meeting webpage too, I believe. Okay, any other questions or comments from any of the other meetings?
Dana, it's Laura. I'll just mention briefly, the Healthcare Workforce Committee met as well. There is some staff changes for the committee. So Mark Overbeck is no longer with OHA. He's taken a position with SOU down in my area. So we are currently, I don't know if a replacement has been identified yet, but we did meet in March, briefly touched on the charter that's being reviewed and also introduced, we had 6 new members. One of those members has since decided that it's not the right fit. And so she resigned from the committee, but we do have 5 new committee members. And then we are doing a educational, I guess we could call it an educational session next week. I believe it's Wednesday morning. I'll send the info and maybe Janet can pass it on. It's just really looking at the charter again, finalizing the charter. It has to go to the OHPB for approval. We're hoping to get that done for May's meeting.
Great. Yeah, I saw there was a lot of new members.
There's a lot. That's good though.
Yeah, that's good. Good. Yeah, good new energy and stuff. Okay. Any other questions or comments? Cheryl, your hand's still up and I'm assuming it's from before.
Oh, sorry, I will unraise.
Yeah, it's okay. Just making sure I didn't miss you. Okay. So I think we're ready for our next topic then. Yes, Jessica? There she is.
Hello, hello.
We can hear you.
All right, here we go. Hi, everybody. My name's Jessica Dushek. I use she, her pronouns. I'm a dental policy analyst on the Medicaid team of OHA. And I've got 2 updates that I wanted to share with you this morning. One is of the handicapping malocclusion work group, and then the other is about the dental OAR revision project. So for the handicapping malocclusion work group, or the HM work group, our first meeting is scheduled for April 22nd. The participants of this group completed a brief survey monkey survey and identified the following as the top 3 priorities for the work group's focus. The first is the administrative burden that's involved in the orthodontic benefit. Some of these burdens include denials based on administrative error versus clinical need. And then also inconsistent review criteria and processes, or providers not being informed of review decisions. So that was identified as the top priority area. Secondly is of clinical regarding evaluations and the automatic qualifiers for the orthodontic benefit. For example, when it is and when it is not appropriate to carry out a pre-orthodontic evaluation. And then we've seen to the cleft lip and cleft palate members who have that automatic qualifier. We've been seeing some denials of those members. And also there's some variation of the review process among the different orthodontic payers, or I'm sorry, the different dental partners. So another area that is our third highest ranked priority area is the communication of the benefit. And that's, for example, for even medical and dental providers, we're learning that the awareness needs to be spread better. There's still some lack of awareness of the benefit. And then even members' awareness needs to be improved. Members and advocates in the community and enrollment staff. So that's a communication concern. And then also wraparound support and service coordination, since there are multiple appointments involved with orthodontia care. So possibly bringing in community health workers involvement more. And also the knowledge of the appeals process. So members who are receiving denials and then wishing to appeal that, there's confusion with the process. So those are the top priorities. We will be meeting, I think I said already, April 22nd is the first meeting for that group. So that's what I have for you for the update on the
Jessica,
handicapping malocclusion.
Can you give us the rundown of who's on the committee?
Oh gosh, I don't have that list up, but
oh, okay. But how many people did you get? Like 4 or more?
Oh, we've got about 20.
Yeah. Okay.
We've got clinical. We have clinical providers, orthodontists, pediatric specialists, office managers of an orthodontic clinic, and there's some few people from OHA also, and we've got some CCO and DCO representation. So we've limited it to one person. One person can represent from each organization. So a couple of the organizations maybe have 2 people who are interested, but they'll just alternate participation.
Hey, Jess, there is a question. Can you email the H&M roster after this meeting? So if you're welcome to send it to me, and then I can make a big email with everything in it.
Absolutely. Yep, I will do that. Then the other update I wanted to share with you is about the dental rule revision project. That is a really big undertaking. I wish I was further along on that project. It's been a bit more time consuming than I had planned or expected. So for the restructuring, or for the dental OAR rule set, that's the 410-123 rule set. This project involves restructuring the rules. So for example, there's going to be new subject headings with new rule numbers being made for them. And then this new structure is going to have the same content, but information will be condensed, or maybe just a quick point to a different rule rather than spelling out a whole lot of information that's cited elsewhere in the 410 general rule. So it's becoming organized differently, and the rules will be more reader friendly, so for health professionals, but also for the community and for myself, needing to understand what the rules are. And right now they've been hard for me to understand at times. So anyhow, we anticipate that the rack will be in mid to late May. We haven't announced that or sent out the invitation.
Oh, yeah, okay. Sorry.
No, it hasn't been announced. No, I'm wanting,
So
I
when-
need,
Okay, I have questions.
okay, awesome. Well, once we complete the internal processes, then we'll be sending out the rack invitation along with the draft version of the revision. Dana, what is your question?
My question was gonna be, when is the draft going to be available for us? Because if it's that big of a change, we're gonna need like weeks to look through it.
Okay. Okay, that's super good. I'm really glad you're telling me that.
Yeah.
And I was wishing to get it out like even 2 weeks ago. It's just that there's so much structural change and internal input. And so, okay, that's super good to know. So you're wanting to receive the invitation and the draft and then have at least a couple of weeks.
I would love to have a month to review the draft before the rack gets scheduled. I mean,
I agree. This is Laura.
Queen of the world,
okay.
I feel like it's going to be, we're going to have to read through the whole thing, right?
Right.
And understand how, the layout and everything else, provide you feedback so that you can make changes before the rule gets drafted. Then we have the rack, right? So I feel like giving us a couple of weeks to be able to give you some early feedback would be really helpful for you as well.
Yes, and that will make the actual rack event go a lot smoother. Having all of that.
Absolutely.
Yeah.
Yeah.
Okay.
So if the
I
rack can be in
appreciate that.
June or something, that
Okay.
might be better. See if you can
Okay.
push it. Yeah.
Okay, I really appreciate hearing that because I go back and forth between the urgency of getting it done quick and then the importance of it being thorough and planned accordingly. So I struggle with balancing those two.
No, I think especially with rules making sure that they get done right. Yeah.
Mm-hmm. Oh yeah, it's been very time consuming. It's very, very, very detailed.
And Jessica, Dr. Manu has a question.
Oh, Dr. Chaudhry, what you got? I didn't see that.
Um,
Oh, here's your hand. Is it?
That's okay. So, yeah, my question is actually related to the previous topic, around the work group for handicap and inclusion.
Okay.
I vaguely heard, I recall that you mentioned that there are representation of pediatric dentists, on the work group. It's my understanding from the memo that was written and submitted in January that orthodontists and general dentists can participate, with the handicap and inclusion benefit. I was wondering if you can provide a little bit more color on the inclusion of pediatrics, with this work group.
Okay, well, we're going to be talking about that memo next month, as you remember what Nathan said. So not talking about the policy behind pediatrics, but pediatric specialists do make referrals of their members, of their patients for orthodontia. And so they experience some of the administrative burdens, and they have experience with where the benefit needs to be improved with processes and guidelines.
Okay, great. Thank you. That makes sense. Okay, thank you for sharing that.
Yeah, you're welcome.
Well, wonderful. Oh, sorry. Go ahead, Jess.
Oh, and I was just going to say one more thing. So regarding the rule update revision and the REC process, and then a little bit simultaneous or soon after is the revision of the covered and non-covered list, because the rule points to the covered non-covered list, and so needing to get that updated as well. So it's in the works. I appreciate everybody's input.
Yeah.
Yes.
Great.
Phenomenal. Thank you, Jessica. And just shoot me the email with the H&M work group and then the 3 big topics that they're going to be focusing on. And I'll get that out later this week.
Awesome. Thank you so much.
Thank you. Appreciate you. Now we have Emily and Mary Beth to give us a legislative update. Thank you all for joining us. I do appreciate it. Welcome to the Aura Health Forum. I'll let you guys have the floor.
Hi, Janet. Hi, everyone. Thank you so much for having us today to talk a little bit about legislative session. I don't have a super formal presentation that I'm going to walk through because I know that there was one particular bill that's of interest to this group, and I was going to spend some time talking through that. But first, we're going to do some introductions. I'm M. Droege. I use she and they pronouns. I am a senior policy advisor on the government relations team. I hold the public health division and equity and inclusion division portfolios. Mary Beth, do you want to introduce yourself?
Yeah, thanks. Hi, everyone. My name is Mary Beth Milieu, and I use she, her pronouns. And I currently hold the portfolio of health policy and analytics, PUB, OEB, and oral health with the Oregon Health Authority government relations team. So
Thanks, Mary Beth. So to kind of just kick us off, short session ended on March 7th of this year. It was a really quick and dirty short session. There was a lot of bills that passed. 35 of the bills that passed have some type of impact on health. We put together, we being Oregon Health Authority, put together an end of session report that you can find on our website. I will share that link to be shared with the notes, or we can share it in the chat right now. Mary Beth, are you able to pull that up? Also, I can also just share it in the chat later. And that report walks through all of those 35 bills that passed that impact health. It also talks about the funding bills that pass that appropriate dollars to Oregon Health Authority. We won't dive into all of that today unless y'all have specific questions about it, but I did just want to spend some time talking about Senate Bill 1578, which I know is of particular interest to this group. So Senate Bill 1578 requires Oregon Health Authority to establish and maintain and administer a healthcare interpreter management system for both scheduling and billing of healthcare interpreters who serve Oregon Health Plan members. So it's really specific to those who are Oregon Health Plan members. It also establishes a training and retention program through a nonprofit that Oregon Health Authority will contract with through a competitive contracting process. And the purpose of that training and retention program is to support folks who want to be healthcare interpreters to receive access to that training and also to receive retention programming, because we see that there's a lot of churn in healthcare interpreters. The interpreter management system will be a voluntary system, so providers will be able to opt in to using that system. There's no plans to make that required at this time for folks to use. And I know that that was a question that was of particular interest to this group. So CCOs will not be required to use the interpreter management system, and other providers will not be required. It's just voluntary. Are there any questions about this bill in particular that I can answer today? Amazing. Fantastic. Mary Beth, were there other bills that we were following during session that you know of that touched on oral health related topics that we can speak to?
yeah, there was the dental laboratories bill, which was creating a registration for dental labs in Oregon. It was part of an omnibus bill, House Bill 4011, that did not pass, and nothing was pulled out of that bill into any other portions of bills. So, I wouldn't be surprised if we saw that come back next session, but this session it did not pass. So, I think that is the only one that we were tracking.
Were there any bills that folks in this space were tracking during session that passed that we can answer any questions about? We're kind of here to just have an open conversation with y'all.
I guess I have a quick question. So the healthcare interpreter bill, I'm assuming there's going to be some rules and such are written around that. Do you know about the timing of any of that?
No, no timing about that. We're still waiting for the governor to sign this one. So
gotcha. Okay.
It's still very much in the early stages of implementation planning. But we'll definitely keep y'all updated as progress moves forward.
Any questions?
Thank you guys so much for being willing to come and give us your time and give us this update to this amazing group. Thank you, Mary Beth. She put the end of session report into the chat. I do appreciate that. Take a gander at it, guys. If there's any more questions or concerns, shoot us an email and we can definitely help you get that answered.
I will also say before we hop off that we have 2 presentations for external partners. The government relations team is putting on 2 presentations this week. So one of them is scheduled for Wednesday at 3 p.m. and another is scheduled for Thursday at 11 a.m. Mary Beth, are you able to quickly grab those and pull those into the chat? I'm so sorry for putting you on the spot to do these things right now, but
No,
I do
it's
want
okay.
to offer that to this group too. So those presentations are going to be a full hour where we walk through all of those 35 bills that have passed. So y'all are welcome to join to see and learn more about every single bill that passed related to health, and we will be there for those as well. And thank you, Mary Beth, for pulling those to put in the chat. I appreciate you forever.
Phenomenal.
I just put them in the chat,
Yeah,
and there it
appreciate that.
includes registration links. And if you need any kind of alternative formatting or accommodation, feel free to reach out to Sarah Herb on our team, and I've included her contact information as well.
Thank you very much. This is thorough and I love it. And yes, please feel free to stay on and listen to updates if you would choose to, or you're welcome just to do whatever you would like the rest of the day. No harm of me. Thank you, Emily. Thank you, Mary Beth. Now we
Thanks
have
so much.
updates. Thank you. Updates from leadership. I believe Dave Embody is on the line.
Yes, hello.
Hello, Dave.
I had a couple things to share. One, Cheryl touched on a little bit already, and it is the CCO restatement process. As Cheryl mentioned, we're going through the significant contract changes and that process, which starts early. I know we're talking about things that will be effective January 1st, 2025, but it's an extensive process in the hopes that the things that we're adding or changing in the contract are well vetted before we get to that point. We weren't sure what to expect, but we ended up with 26 proposed changes that we've identified as significant enough to vet, not just internally, but externally. And so we're in that process now. And most of that happens through the Ops Collaborative meeting and the Contracts and Compliance meeting in April and in May, where we'll initially we start doing an internal review to make sure that it kind of makes sense and something that's worth pushing forward. And then we bring to those meetings to vet with CCOs and have discussions. And as was mentioned earlier, it's a great opportunity to see if we miss something or if something doesn't make sense or unanticipated implications of some of these changes. It's a good time to do that. And along those lines, one of the items that was proposed were potential expiration of new proposed directed payments. And one of them was to look at potential dental directed payments. And so you'll probably see efforts. We were looking at potentially using a component or a period of the next month. And tell me if I'm off on this, Janet, but to use a portion of next month's meeting, maybe to touch on that. Because this is an area where we definitely want input from this group about your thoughts around it. And this is something that was proposed through our OAFA group, which is our actuary and financial group that often touches on the financial components of the CCO contract. And so this is one area that, like I said, it's something that would be definitely, I suspect, of interest to this group. And we're looking for your your input and your thoughts about that potential proposal. So we're still trying to coordinate that, but the intent is to try and get it to next month's meeting as a discussion. The other part of it that we're doing that's new this year, and we're kind of tiptoeing into it, but we'll hopefully take some positive steps, is to try and also engage the community and members in this process. And so that will be happening probably in the month of May. But some of this, like I said, this is our first year doing it, so we're going to take initial steps with the idea that as we make improvements to this process each year, that we can expand on that. And part of that comes from the fact that there have been opportunities where we do work through CCOs that recognize that the implications of some of these changes go beyond just the CCOs, even though it is specific to the contract we have with them. And so in those circumstances, we're looking to solicit input beyond just the CCOs and the internal input that we get. But to continue in this process, as Cheryl had mentioned, we send out a draft version of the new restated contract in June to CCOs, and they provide us with their feedback and their input, and then ultimately this leads to a signed contract by the end of the year. Any questions on that, or any thoughts? I know that we've kind of tiptoed around parts of that along the way, but I think one of the places where this group can be incredibly valuable is when we do have particular contract elements that touch on dental components of services provided, that there's always an opportunity for input there. Yes, Sam?
Thanks, Dave. And thank you for following up about the directed payments conversation. I appreciate it. As you know, we did put in a request to OFA to have a meeting with DCOs, CCOs, and ODA. So I appreciate that follow-up. With the deadline of OHA needing to have any directed payments innovation figured out by June, are we going to be putting ourselves at risk of not having this conversation until May? And is there anything we might do in the interim with a list of questions we have or anything like that to keep the conversation on track so we don't miss that opportunity? But I appreciate you bringing it up in May. Don't think this is criticism. I'm just calling out the timeline. So thank you.
Yeah, and just to be clear, this is one component of a series of meetings that we're having. For example, there'll be an extensive discussion of this at the next rates work group as well. Internal discussions have already started on all of the significant contract changes. So, like I said, this is one component of a multitude of different discussions that happen as it relates to each one of these significant contract changes. So yeah, to your point, yeah, the discussions have already begun, and this is an additional piece of that the discussion that'll happen in early May.
Thanks, Dave. I think you know, obviously understand why CCO rate setting work group is where the final negotiation happens, but with the concept of directed payments, if it's anything similar to behavioral health, requiring metrics and things like that that are really clinically informed, I think that's where we just want to make sure there's a gap that's being filled with the clinical knowledge of the subject matter experts in this team.
Yeah, absolutely. And that's where I think it is important that we find space for this group to examine it and provide their input on it.
Thank you.
Any other questions or comments? The next thing I wanted to touch on was just to provide an update as it relates to the ongoing redetermination process. I think sometimes this is one of our big projects, but it sometimes gets lost. And I think probably for positive reasons, that I think it's going exceptionally well. And so you don't necessarily hear about it because there's not a lot other than it's moving forward. We, of the nearly 1.5 million people that had to go through this redetermination process, which this is basically as we came to the end of the public health emergency, there was a requirement at the federal level for each state to redetermine whether those who are currently covered under Medicaid continue to qualify for that coverage. And so we literally have to go through and review every current member to see if they still qualify. So of the nearly 1.5 million people that are currently on Medicaid, the process has been completed on about 88%, or about 1.3 million. And of those, 84% have qualified to continue for renewal, which actually is pretty good, not just for the state, but it's pretty good nationwide. That makes us the third highest state in terms of maintaining people's coverage for Medicaid. So that's exciting. And as this moves forward, the intent is to ensure that where we can continue to provide healthcare coverage, we will. But like I said, there's been a lot of incredible work going on in the background that has made this the quiet big project, which I think, again, is a great opportunity to see that there is some great work being done around this. And I don't know, maybe some of you have had the opportunity to attend the biweekly meetings that occur each Friday, or every other Friday, where updates are provided. But this, I think, has proven to be a pretty effective means to not only provide communication, but to highlight and identify places where challenges have existed along the way, and to try and answer questions and provide information. So we'll continue to keep you posted on that, but that's one that is definitely moving along in a positive manner. Slightly related, the Bridge Plan, which is our development of a program to expand healthcare coverage to those that have 100 or have are at 138% to 200% of the federal poverty level, is still moving forward with the intention of going live on July 1st of 2024. So we're kind of in those key moments as we near the end. We're doing things like finalizing the rules, finalizing what will be a brand new contract with the CCOs. And just in terms of timeline, the final opportunity for public comment on those rules, the deadline is April 21st. So a few weeks left for that, but there is a public hearing that'll occur around the rules on the 15th. So that's an opportunity to provide input. In many ways, this contract is very similar to Medicaid, with a few exceptions, but the idea of expanding that coverage. And this is one of the ways where I think we're able to continue to provide healthcare coverage for many of those that would normally fall off of our Medicaid program through the redetermination process. The contracts will basically be going out to CCOs at the beginning of May, and they'll have a month to review to get it back to us. And then, like I said, it'll launch on July 1st. So it's pretty exciting. And again, another place where a lot of pretty extensive work's been done to get us to this point, but that one is moving forward. The other, and this is a project that's kind of coming down the tracks, but we'll probably hear more about in the months ahead, is the next CCO contract procurement process. Our expectation is that that'll kick off more formally this summer. Just to let you know where we are, in the 2023 legislative session, the Oregon legislature had identified the need for us to extend the existing contract for 2 years, which basically means that the current contract that we have with CCOs will end at the end of 2026. So we have to go through a procurement process for the next one that would start the January 1st of 2027. But that process is a pretty extensive one. So like I said, it'll probably kick off this summer. The initial steps that are going on now is we had provided information and had conversations with the governor's office. Typically before this work kicks off, there's kind of some direction provided by the governor. At least that's what's happened for the previous 2 times that we've gone through this process, usually providing some overarching goals or some direction. And so we'll be looking for that, and hopefully be receiving something in the coming months, with the idea that we'll be kicking off in July. And just to give you kind of a high level timeline for this, that work starts in July, and a lot of that is going to be looking at kind of what's going on with the current contract. Are there gaps in that current contract? Are there things that we can change? Should the relationship between the CCOs and OHA be adjusted? Any of those things. It's kind of reviewing the existing contract at a more comprehensive level and seeing what potential changes need to be made. It also will include pretty extensive community engagement. And the governor has provided direction that she definitely wants the Oral Health Policy Board to be a key element in that process. So our expectation is that they'll be doing community engagement efforts pretty extensively, probably either the end of this year, beginning of next year. 2025 will be a pretty busy year for developing the process itself and also developing content changes, with the idea that we would probably release the procurement request at the end of 2025. And that's where individual organizations can apply to be CCOs for the coming contract, with selections being made in early 26, and then putting together that new contract and the related oversight responsibilities. So look for that. I know that it seems like a long way away to think January 1st, 2027, but the reality is that effort will probably be starting in a few months. So look for that. The last thing that I have is just wanted to mention that we are in the process of adding a number of new staff to our CCO operations team. You'll start to see them popping up in different places, but just to give you some highlights, we do have a new person focused exclusively on rules, who is Darren Kaufman. And I know he was on the call a little earlier. And so you'll probably see him, for example, the discussion that Jessica provided as it relates to the dental OAR work. He'll definitely be participating in that. I see that Leslie just jumped on. I don't know if you want to introduce yourself, Leslie.
Hi there, I'm Leslie Ains. I am the manager of the quality of care for the quality assurance team, and a nurse by profession. And so I'm looking forward to working with this group. I'm excited to be here. Thank you.
And Leslie is actually one of 3 new managers that we've added to our quality assurance team. So they do a lot of the work around the oversight and compliance associated with CCOs and CCO requirements. And so you'll probably see those 3, as well as some additional members on their team joining as well. So just wanted to throw that out there. So if you start seeing some new names, there's a pretty good chance they might be some of those new people that we've added to the team. So hopefully part of this is that we'll also be able to provide greater support and provide greater resources for this and other groups. So I think that's all that I have for now. I want to see if there's any questions or comments. And I don't know if Meg has joined us yet.
Yes, she has.
Oh, great. So she's got the really exciting news, or the one that you're probably most interested in. So I'll turn it over to Meg.
I'm not sure if this is most exciting, but certainly the most long awaited. We are starting to set up our interview processes for the new dental director. We have received a number of applicants. The position will be posted all the way through April 15th. So we are by no means done with recruitment, but are very thrilled with the number of applicants that we have received thus far. We are recruiting nationally. What I would love to get from you all, and I will put my email in the chat when I finish speaking, is any feedback from how the community partner panel went this past summer in our last recruitment. So if you all, those of you who had experience with that, if it worked really well, please let us know. If there are things that you recommend changing for this interview time, please let us know. Again, to remind everyone of the process, we are really committed to having you all involved in interviewing the candidates and providing some feedback, knowing that you will be close partners with the dental director. So we will be having screening interviews or initial interviews internally. We would love to include you all in the feedback and meeting some of the final candidates. And then OHA will have the final selection round, incorporating feedback from the initial interviews and community partners. We also continue to be committed to having a diverse representation of community partners from DCOs, CCOs, FQHCs, and that is who was represented in the community partner panel last time. So I'll pause for a quick moment to see if anybody has some initial feedback about how that went or not. I think last time we really deferred to you all on who should be part of that panel. You know, your community members certainly better than I do, but we also, you know, are happy to help seat that table if that would be helpful as well. We're looking for some thoughts on kind of balancing what you all would like to direct, how you would like our support in that. Gary.
Yeah, thanks for the opportunity for input. You know, as a participant in that community partner discussion, I thought the process went very well. It was a facilitated process, and I would recommend that that same format be continued so that there's consistency from one candidate to the next in asking the questions. I think with some of the restructuring, we might want to relook some of the questions we had agreed to and make sure that those are still valid. But overall, I thought that the process went very well. So thank you.
Thank you so much. And thank you, Gary, for reminding me of that process for the questions. I agree. So far, we have more applicants than we had last summer. And so I would anticipate that this group would talk with anywhere between 2 to 4 candidates. And so, as you mentioned, the participants in the panel drafted some questions, our team reviewed as well, and we collaboratively refined those questions. And then you all had the set of questions that you asked. Colleagues from public health helped facilitate the conversation. So thank you for that feedback, Gary, and also for providing a few more of those details. And if that continues to work, that we can do the same process again. I agree, we want consistency across all of the candidates in terms of how y'all are facilitating the conversation, recognizing that, you know, also the conversation will go where it needs to go. Laura.
Hi, Meg. This is Laura with All Care. I think I second what Gary said. I thought the process went really well. I really appreciated the diverse group that was in the panel that was put together. And, you know, I'm trying to remember the first time, Gary, it was a little bit different, I think, when we did the first round. We still had questions, though, I believe. And then this last time, I think we each submitted the questions, and then, like you say, it was reviewed for feedback. But I thought the process went really well, and I just appreciated being included in the process of visiting with the candidates.
Thank you, Laura. I appreciate that feedback. I'm glad it went well. Manu, I also see your thumbs up in the chat, so I will interpret that, unless you state otherwise, as agreement with what Gary and Laura have said thus far. Well, thank you all. I did put my email in the chat at 10:36, so if there are additional comments, I welcome you to send them my way. And I anticipate that this panel will be scheduled sometime in May. We are working on scheduling things a little bit more in advance. Like I said, the position will close on the 15th of April. So don't expect anything before the 1st of May, but I will, myself or a colleague will be in touch to recruit participants for the panel and to further detail the process. And thank you all again so much for making time. I appreciate you elbowing this into your busy schedules. Like I said, your views and your feedback is really important to us in this hiring process.
Thank you, Dr. Carey. It's very exciting. Yay.
It is indeed. We're looking forward to having a dental director.
Are there any other questions for Dave or Meg?
I just wanted to confirm, so I don't know, Dave, if you heard, we were talking about our meeting next month and possibly, well, yeah, changing the times and stuff. So we definitely are keeping our May meeting on the 7th. So I'm assuming that the folks from rates were able to make that day and time when we're talking about them coming to present at that meeting. We want to make sure that we're on the same date.
Yeah, and we'll confirm that. But yeah, just to clarify, that it is the same second Tuesday or first Tuesday of the month in May.
Yeah, okay. Thank you.
Well, that's wonderful. Thank you, Dave. And like Dave said, we will keep everybody updated on the agenda for next month. And that on those coattails, if y'all have any agenda items that you'd like to see in the next 3 to 6 months, knowing that sometimes it takes a little bit to get people on this schedule or the information is just not yet available, please go ahead and email me and the chairs so we can make sure that it is brought appropriately to the agenda setting team. And anytime an idea pops in your brain about what might be a good agenda item, please go ahead and email us so we can always keep it on the forefront. Dana, Laura, is there anything you would like to bring to the table?
Nothing from me.
Yep, I'm good.
Are there any other comments or questions? Phenomenal. Well, the next meeting is a hybrid meeting. The date is May 7th. The room, I will get out to you which room we're going to be able to tackle. And I'm hoping to see a lot of you in person. And I hope you have a lovely day. And thank you for everything you guys bring to the table. Thank you.
Thank you. Thanks, Janet.
Thank you. Take care, everyone.
Thank you. Bye-bye.